I used to work in the public relations department at a state hospital near Seattle. It was the department where all sorts of nonsense got dumped when no one wanted to figure out who it belonged to, or they just wanted to pass the problem off as far as possible. It was tough handling the workload when we had a yes man director of public relations who usually agreed to almost any request for help, especially after other staff threw out standard excuses like, this involves a patient, so let PR deal with it. Or they'd butter us up. You guys handle this so well, we'd just screw it up. Better you take it on. Besides the PR department, there was the medical affairs department, which dealt with more complex cases, legal, intricate medical, or interdisciplinary issues. Due to the nature of the work cases, sometimes bounce back and forth between these two departments. This particular case was partly handled by me, but my colleague took it to the next level by maliciously following the rules. Cast of characters: Cynthia, director of the medical affairs department; Joel, medical affairs department employee; Sarah, financial department employee; Mr. Nelson, the patient, a retiree with no income. Now, the story itself. This happened almost 10 years ago at a state hospital near Seattle. Mr. Nelson underwent surgery. Everything went smoothly, and a few days later he left the hospital to recover at home. At home, he meticulously studied the bill sent to him, called the hospital about an alleged error, and was transferred to me. For confidentiality and simplicity, let's call the disputed item an organ transplant. Mr. Nelson insisted no organ transplant took place. He only had a couple of medical devices installed. At that point, he was still fairly pleasant to talk to. I assured him I'd call back after checking. Since this case wasn't urgent, it took the financial and surgical departments about 2 weeks to sort out the details and figure out what happened. Meanwhile, by the end of the first week, Mr. Nelson started sending me emails asking when he'd get the promised refund. Curiously, I didn't recall ever promising a refund. Per internal company policy, I was required to respond to each of his emails. By the time the finance team finally gave me a detailed response about his case, I knew his email and phone number by heart, and he was getting more and more irritated. I contacted Mr. Nelson and confirmed he was right. No organ transplant occurred. The organ transplant listed on the bill was actually a shorthand for a bundled service package that included many items used during his surgery, including the installed medical devices. The surgical department, aware of his financial situation, had provided this bundled service to save him money instead of billing each item separately, which would have been significantly more expensive. My response flipped a switch in Mr. Nelson's brain, and he just exploded. He yelled that a state hospital funded by taxpayers should act more honestly, and demanded the bill be revised to fully reflect everything performed and used during the surgery with no exceptions. Even when it was explained that this would likely result in a much higher bill, he didn't back down from his principles. I was still a relatively new employee, so I told Mr. Nelson I needed to consult someone to see if his request was possible, and ended the call. At that moment, Cynthia approached and asked if I was okay. She'd passed by as the call was wrapping up and stayed noticing I was upset and nervous. I told her what happened, and she kindly offered to transfer the case to her department since they were used to handling such cases, and it wouldn't be a big deal for them. I agreed without hesitation, as I was already fed up with Mr. Nelson. The next day, I called him to inform him that Joel would take over his case. After that, I heard nothing more about the situation from Joel, Cynthia, or Mr. Nelson, and completely forgot about it. Until 4 years after that incident, a major reorganization hit the hospital. Cynthia and Joel quit, the medical affairs department was shut down, and the PR department was merged with several others. Now it deals with even more nonsense. One fine day, Sarah from the financial department called me about a patient, claiming he'd spoken with staff about a billing error, and his issue remained unresolved. Sarah wasn't sure, as the patient insisted he'd dealt with Cassandra Gordon, and Arthur categorically refusing to acknowledge Cynthia Joel, or me, when Sarah tried to clarify if it was us after archaeological digs through archives and medical records. It turned out the caller was Mr. Nelson, and it was the same issue, but with an unexpected twist. Apparently, when Joel contacted Mr. Nelson, he tried to explain that fulfilling his demand for a detailed bill would lead to significant additional costs on his end. Mr. Nelson flat out refused to listen to any explanations and started yelling, lecturing Joel on morals. Moreover, he threatened to report the hospital's alleged illegal actions to various state agencies, and judging by later events, apparently did contact at least a couple of them. I have to admit, Joel was far more professional than I was, usually the epitome of calm and composure, able to endure tons of nonsense without wanting to kill anyone. Clearly, Mr. Nelson deliberately acted in the worst possible way, because in 4 years of working there, I'd never seen Joel behave like this. Typically, in such cases, Joel would pass the case to Cynthia with a recommendation to ignore the request or send an official letter and close the matter. Cynthia usually agreed if it was a morally justified decision without legal or medical consequences. But this time, Joel didn't do that. He decided to fulfill Mr. Nelson's request. He told the surgical department what happened, furious that their goodwill had been rudely rejected and trampled. The surgical department agreed to the changes and brought in the financial department to ensure every procedure, every tool, and every item used in the surgery was painstakingly itemized in the bill. No bundled services or attempts to save Mr. Nelson money. It turned out the organ transplant wasn't the only item listed as a bundled service to reduce costs. As a result, the bill doubled. Mr. Nelson was livid when Joel sent him the new detail bill. He refused to pay it, and for about a year periodically harassed Joel with threats and complaints until he eventually vanished. I asked Sarah why Mr. Nelson resurfaced after so many years. Apparently, a collection agency found him. Mr. Nelson had moved and didn't update his contact info. He also skipped medical checkups. At the hospital, unpaid bills are eventually handed over to collectors who use the contact details in the hospital system. And so, after all these years, Mr. Nelson finally showed up for a medical checkup and was forced to provide updated info. The collectors quickly learned of it and resumed the debt collection process. Somehow, I managed to dig up the last remnants of my nearly exhausted compassion and asked Sarah if there was any way to undo the changes. Sarah laughed and pointed out that thanks to Washington's state insurance available to all citizens, Mr. Nelson's initial medical expenses were covered about 80%, largely due to special bundled services like the organ transplant used by the surgical department. However, after his demands, the insurance covered only about 30% of the new bill, which had already doubled. And the best part of all this is that such bills are submitted to a state authority, and only one change is allowed unless the hospital officially admits an error, which could lead to hefty fines. This rule is in place to prevent hospitals from arbitrarily altering bills and to reduce administrative costs. And here's the miracle of miracles. One of the agencies Mr. Nelson complained to about our supposed illegal actions was the very one responsible for covering medical bills. So the state agency not only knew about his not so smart demands, but also knew we tried to help him, only changing the bill at his own request. And naturally, the hospital wasn't about to take a fine for Mr. Nelson's sake. With immense, genuine pleasure, I made the final call to Mr. Nelson. He didn't recognize me, but I took great satisfaction in reminding him. It was me who first spoke with him 5 years ago. Did he remember me, the one he yelled at back then? No, oh, no big deal. So much time has passed. Oh, it's not about the time passing, but that he didn't think it necessary to remember our names because we're just customer service staff. Fine. After that, I didn't continue with polite small talk and went straight to the point, informing him that we couldn't revise the bill again, as changes are allowed only once. Surprisingly, he didn't snap right away and even asked why. I explained. There was a long pause, and just when I started worrying he might have passed out, Mr. Nelson exploded, screaming that it was all a lie, that we're dishonest, that he's a penniless retiree. How could we do this to him? Why did we make the changes knowing the total would increase? How could the new bill even be higher? It must be a mistake, and so on and so forth. By that time, I was an experienced employee and usually ended such calls after 3 warnings. Dear readers, with Mr. Nelson. I didn't do that. I patiently waited until he ran out of steam, shouting insults, and in the ensuing silence, I simply said, the bill was itemized and changed at your request. Laughter, sir. Edited. I saw several comments claiming that Mr. Nelson wasn't informed of the surgery's estimated cost beforehand, and other discussions on this. Sorry for not mentioning these details initially. I thought they weren't that important as the story was already quite long. But for clarity, I'll specify. Mr. Nelson was informed of the approximate cost range before he agreed to the surgery. If I remember correctly, his initial final bill ended up slightly higher because complications arose during the surgery and more medical items were used than planned. Nevertheless, the amount still stayed within an acceptable range thanks to the hospital accommodating him with bundled services. And secondly, Washington has available financial assistance options, but Mr. Nelson rejected all the offers when we presented them. To put it mildly, his response was something like, "What, you want me to humiliate myself and beg for help?" No, Mr. Nelson, we really just wanted to help you. Honestly. Well, at least until the moment you drove even Joel to his breaking point. Edited number 2. I didn't expect I'd have to add this, but surprisingly, many people are worried about Mr. Nelson's health and financial situation. You're all incredibly kind people. Let me reassure you, Mr. Nelson's health and financial situation were never at risk. Some hospitals have interconnected medical databases, but their payment systems aren't linked to each other. Mr. Nelson always had access to a wide range of medical services elsewhere, and he would never have been left without medical care or financial support if he'd chosen to seek it. Moreover, he could have even repeated this scheme, get surgery, and disappear at another hospital if he wanted to gradually shrink the list of facilities available to him. In fact, I'm almost certain that's exactly what he did for 3 to 4 years, until he showed up at ours. Perhaps he hoped we'd have forgotten about his laughter debt by then. Sorry for the inappropriate chuckle. Second story. Pharmacy staff refused to stay late. Just once I complained to their boss and their workday was extended by an hour. I once worked as a pharmacological research coordinator at a hospital in Seattle. If you work in medicine, following prescribed laws and rules is critically important. Problems start when people begin inventing their own rules and operating by them. The toughest part of my job was convincing other departments to do their duties. Sometimes it was incredibly difficult. You had to beg them even for basic tasks. Ask a nurse to take a simple blood sample in 4 vials. They roll their eyes. Ask pharmacists to stay 5 minutes past the end of their shift. No, they can't do that. They're out the door at 4:30 p.m. sharp. That second scenario is key to this story. The pharmacy department categorically refused to stay late after work. I understand why they'd want to stick to a stable schedule, but in a world of sick and dying people, unforeseen situations sometimes arise. For the record, I regularly had to stay 1 to 2 hours past the end of my shift to deal with issues or fill in data. In my department, that was normal. We were calmly paid overtime or given a flexible schedule. Our hospital was located in Seattle, a city with very snowy winters. A few years ago, a big snowstorm was expected. Every one of us, nurses, doctors, pharmacists, and coordinators, was critical staff and required to show up for work regardless of the weather. So we all had to come in the next day, no matter the weather. If we didn't show up due to weather, we'd have to take sick leave. The day before the promised snowstorm, we had a patient at the clinic. Usually, patients in this specific study first saw the doctor, then received treatment right afterward. However, this person, Mr. Carter, had a job that made him prefer daytime checkups and getting treatment early the next morning. It was unusual, but we easily accommodated. Although most of us resigned ourselves to the need to drive in the snowstorm the next day, the experimental drug department was particularly unhappy about the prospect of coming to work during a blizzard. So at 3:30 p.m., an hour before the pharmacy closed, they sent me a message on Slack asking if it was possible to treat Mr. Carter today, so they wouldn't have to come in tomorrow. Seriously, you're asking this? Now, nevertheless, I reluctantly went to the waiting room and asked Mr. Carter. He wasn't thrilled, but said he was willing to get treatment now if necessary. I informed the pharmacists. Then they asked me about Mr. Carter's status. The clinic, as usual, was running behind schedule, and the patient hadn't yet been cleared for the procedure. The experimental drug department needed at least 20 minutes to prepare the necessary medications, so they set a deadline of 4 p.m. to receive the doctor's signed prescription. The process for obtaining the medication was as follows: obtain a prescription signed by the doctor after the patient was officially cleared for the drug. Take the prescription, cross the street to the pharmacy, hand the signed prescription to the pharmacist, wait for the medication to be dispensed, and return with it to the patient in the first building. It was blatantly obvious that doing this in about 12 minutes was simply impossible. At 4:01 p.m., a pharmacy employee sent me a very rude message on Slack, essentially saying that I had in effect missed the opportunity to treat Mr. Carter today, and that next time I should try harder. Coordinators get blamed for everything, even if the reason is poor time management by the doctor. The message sounded something like, if you don't deliver the prescription to the pharmacist by 4:05 p.m., we won't be able to help your patient. In the future, you should obtain the signed prescription in advance and give it to us for preparation. By in advance, they meant a situation where the patient was prescribed the drug before the doctor officially confirmed they were ready to receive it. During my training, the pharmacy director, Dr. Emily, strictly warned us never to do this. It was categorically forbidden and could lead to a massive lawsuit if something went wrong. You can't prepare medication until the patient is officially cleared by a doctor. I really like Dr. Emily, and I regularly consulted with her about medications patients could take during studies. However, she wasn't deeply involved in the day-to-day operations of the pharmacy staff and focused more on broader strategic tasks. That's why her employees started inventing their own rules and requirements. So I need to treat Mr. Carter today, right now. Fine, since you insist. So I obtained the doctor-signed prescription before the doctor even examined the patient. The doctors frankly didn't care much. The next step, according to the person who sent me the message, was to deliver the prescription. To the pharmacist, you said I had to get the prescription to a pharmacist by 4:05 p.m., right? But what if instead of going straight to the pharmacy, I went directly to Dr. Emily? She's a pharmacist too, and could do everything the experimental drug department staff could. I told Dr. Emily that Mr. Carter hadn't been officially cleared for treatment yet, but the pharmacists were urgently asking me to issue the medication early so the patient wouldn't have to come in during the snowstorm. She looked surprised and asked if Mr. Carter had rescheduled during his clinic visit. I said no. It was a request from the pharmacy staff who didn't want to come in bad weather. I showed her the message sent by her employee. Dr. Emily was clearly displeased and stated that someone would have to stay late if that was the plan. I showed her the Slack message saying I had already missed my chance, as the staff weren't going to stay past the end of their workday. Dr. Emily was furious and declared that she would personally stay late to oversee the issue. We headed to the pharmacy together from her office. She wanted to chew out that employee, but of course no one was there anymore. In the end, we picked up the medication at 4:35 p.m., and I delivered it to Mr. Carter. A week later, Mr. Carter called and said he liked receiving treatment on Thursday afternoons instead of Friday mornings, and wanted to stick to that schedule going forward. I relayed this request to Dr. Emily, expressing doubts about how we could organize it on a permanent basis. She said she'd handle it and get back to me. A few days later, we all received an email stating that the experimental drug department would now operate until 5:30 p.m. daily, and one employee would stay late on a rotating basis to cover evening medication orders. But I knew there were only 3 pharmacists in the department, all on salary, not hourly pay. That meant someone would have to stay late more than once a week. A few weeks later, around 4:45 p.m., I went to pick up the next dose of medication for Mr. Carter. The same employee who had previously asked me to break the rules, Lisa, was working. I asked how she was doing, and she responded with obvious irritation that she now had to work from 4:30 to 5:30 p.m. 3 times a week, probably as punishment for her unethical behavior. A few weeks earlier, she had handed me a pill pack and slammed the window right in my face. And yet, if the pharmacists had just calmly done their job as required and come in during the snowstorm, once they would have continued to leave for home right at 4:30 p.m. If you work in medicine or medical research, don't invent your own rules. Well, that's all for today's stories. Thanks for watching this video to the end, or listening to these stories in the background while cleaning, cooking, studying, or whatever else, as you write in the comments. Check out our previous videos, which you'll see right here. Subscribe to our channel, and good luck to you.